Hello, everyone, and thank you for organizing committee and the moderators for the opportunity to present. I'm going to use this opportunity to present to you a novel technique to prevent or minimize LVOT obstruction when doing TMVR, and I'm going to use a couple of illustrative cases. I have no financial disclosures in relation to this talk. Transcatheter mitral interventions have gained a lot of momentum. Mitral clip is now an established therapy, but sometimes patients do not fit criteria or are not a favorable candidate for mitral clip insertion. So valve in the mitral position, TMVR, has been used in valve-in-valve, valve-in-ring, and valve-in-MAC. The problem when you use a transcatheter valve in the mitral position, that the risk of the LVOT obstruction is reported as high to be as 30%. And the risk of developing LVOT obstruction is usually related to multiple factors. Some of those are modifiable, some of those are not modifiable. The dimensions of the LVOT, you can't really change that. The angle, the aortomitral angle, you cannot really change that. Septal hypertrophy actually is one of the risk factors that some people have proposed doing a preemptive septal ablation. The length of the anteromitral leaflet and how redundant it is, especially in myxomatous valves, is a significant risk factor for developing LVOT obstruction, and the position of the valve implantation also plays a role. So pre-procedure planning, you all know about this, CT and TEE is performed. Let's talk a little bit about the aortomitral angle, and the more acute the angle is, the more risk for LVOT obstruction, because as you can see, the anteromitral leaflet will tend to prolapse and get into the LVOT. And deploying the valve, as you see in G, not only does the valve itself protrude into the LVOT, but actually pushes the anterior mitral leaflet like a sail into the LVOT, causing significant LVOT obstruction. Keeping in mind that LVOT obstruction is more common in valve-in-native valves, because the leaflets are usually more redundant. When you have a valve-in-valve, biprosthetic valve leaflets are less likely to cause LVOT obstruction. The concept of the neo-LVOT has been described, and it can potentially predict who is at risk for LVOT obstruction. We'll skip that. So we did 3 cases using this novel approach, and this is one of the illustrative cases. All cases were deemed to be high surgical risk, not a candidate for open mitral valve replacement, and they were all deemed to be not a candidate for mitral clip because mostly of calcified restricted posterior mitral valve leaflet. This is one of the cases, and as you can see here, some septal hypertrophy, and you can see the anterior leaflet at the end of this cine run or echo run will actually oppose to that hypertrophied portion of the myocardium. So a couple of theoretical approaches have been proposed. The Lampoon procedure have been proposed by Adam Greenbaum and Bill Babliaros. It's fairly complex, where you actually go with a catheter across the aortic valve, and you bovie your way through the anterior mitral leaflet, snare that, and lacerate the anterior mitral leaflet intentionally to prevent LVOT obstruction. It's a very complex procedure. I'm sure some of the people in this room are more comfortable with it than we are, but it is definitely a complex procedure. The surgeons have adopted a different approach, and what the surgeons do most of the time is that they actually get into the anterior mitral leaflet, they create a hole in the mitral leaflet, and they position their prosthetic valve inside that defect in the anterior mitral leaflet, and they call that chordal sparing translocation anterior mitral leaflet. So when we had these cases, we sat down as a valve team, and we thought, what is the best approach to get into this? So the proposed approach was to go through a transapical puncture and to puncture the anterior leaflet with a pericardiocentesis needle, introduce a wire across that puncture, balloon the anterior mitral leaflet, creating a defect and a hole, and deploy the valve in there. And this has been described as first in man in this publication, and I'll refer you to the rest of the team who actually participated in the publication and the procedure. So let's go through the steps, and I'll be very interested in getting input and feedback. This is the pericardiocentesis needle through the transapical approach. This is the surgeon moving the needle into the LV, and this is probably the most challenging portion of the procedure, where the surgeon has to navigate the needle to find the anterior mitral leaflet and penetrate the anterior mitral leaflet using that needle. A reasonable approach is to actually get into the apex, put a J-tip wire into the left atrium, introduce the needle over that, and then withdraw, and then you'll have a little bit more of a focused range or field rather than going blindly. This is clearly a very TEE guided approach, and we've actually used a surface probe on the heart itself through the transapical approach. This is what it looks like on 3D. You can see the needle across the anterior mitral leaflet. This is the TEE 3D. This is a surgeon's view, and you can see that the needle actually is in the middle of the A2 position of the anterior mitral leaflet. Following that, over the wire, a transapical sheath is placed, and then a balloon valvuloplasty is performed of the anterior mitral leaflet itself. Remember, the wire is penetrating through the anterior mitral leaflet itself. You can see on the bottom here how the anterior mitral leaflet yields after the waist is, there's the waist, and pop, it yields. And that's what it looks like when the balloon is inflated through the defect in the anterior mitral leaflet. The position of the perforation is very important. If you position it too basal, close to the annulus, especially in calcified leaflets, the inflation of the balloon may actually injure the annulus. And this can potentially lead to very serious complications. If you position it too close to the tip of the leaflet, you may not get the desired result with actually minimizing LVOT obstruction. After that, over the same wire, through the same defect, the sapien valve is positioned and is deployed in the usual 70-30 approach, and then a flaring of the ventricular portion of the valve is performed. And this is a 3D TEE depiction of the valve into the anterior leaflet being deployed, and actually the sapien valve is expanding within the anterior mitral valve leaflet defect all the way, and this is the final result. There is no paravalvular leak, perfectly functioning valve, and as you can see here, the valve position is excellent without significant LVOT obstruction, and these patients did very well, 100% procedural success, and very, very good results. So in conclusions, this is a novel technique, especially in transapical, to minimize LVOT obstruction in patients who are predisposed to this potential complication. It's a fairly simple approach, although it does need a little bit of dexterity and navigation in the needle. Transapical approach at this time, we have developed another approach used for the transeptal, using the same concept of translocation of the anterior mitral valve leaflet using a balloon valvuloplasty within a defect penetration of the anterior mitral valve leaflet. Thank you very much for your attention, and if you need a reference, this would be the paper that was published. So, happy to take any questions, input, comments, suggestions to improve.
I mean, all these great ideas that are really, coming up now. How long do you think we're going to do these, more complicated procedures now that we have transeptal mitral valves in feasibility trials? We have, how long do you think we really need this?
So, the risk of developing LVOT obstruction applies to any prosthesis developed or implanted in the mitral leaflet. So I've talked to several of the people who are involved in the trials, and Alan may actually chime in on this. A significant portion of these patients are excluded if there's a risk of LVOT obstruction. And because of the trials being feasibility and safety and efficacy, they don't want to muddy the waters with any potential complications. So if the potential is you have an anterior leaflet that is redundant and potentially would be pushed into the LVOT, using a lampoon or using the translocation technique may be of great benefit, especially the fact that if you're using a transapical approach, this is fairly easy. And as we develop the transeptal approach, this would be one extra step, is just penetrating the anterior leaflet and ballooning it. And then you deploy your valve as you usually do, and then you really don't have to worry at all about any LVOT obstruction potential.
A couple questions, great example there. So when you're ballooning, what size is the balloon?
We usually use between 18 and 20 millimeter aortic valvuloplasty balloon.
So have you had issues with just torrential MR in between when you're trying to get the valve in place? I mean, that might be more of an issue with transeptal.
Correct. So what we've done actually, and we've learned from the lampoon people actually lacerate the valve and the leaflet and they get torrential MR. Because of this, our surgeons were very, very reluctant to do this without any protection. So all three cases that were done on cardiopulmonary bypass. And as you can see, we didn't need to pace the patients when deploying the valve in the mitral position because we had complete flow on the cardiopulmonary and almost cardiac arrest or no cardiac flow.
That was a really great presentation. How do you gauge where to cross, where the angle where you actually cross the mitral leaflet?
So this is, again, not easy. TEE guided, and the first case, we get through the apex, and the surgeon starts to advance the needle under fluoro, and we end up in the septum. So he pulls it back and redirects it, and he ends up in the atrium. And it takes a couple of trials until you actually get into anterior leaflet. And then when you get in the anterior leaflet, one case we were actually too basal, too close to the annulus. So we had to withdraw and sort of move a little anteriorly and get, it's not 100%. Again, with the lampoon, you see the diagrams and the images, it's not 100%. You get close enough to where you actually have purchase on the valve, a leaflet, and then you perform your procedure. And the concept and the purpose here is to minimize LVOT obstruction. It's not plastic surgery, so you want to get a good result.
Congratulations.
Thank you. Go ahead, sir.
It's a great case, and a bunch of us under the leadership of Guerrera, we published the one-year outcome of the valve and MAC registry. And what was interesting was that up until this point, there are more valve and commercial available valve put in mitral position than all the transcatheter, dedicated transcatheter mitral valve, all combined. And
They're still in trials, though, right?
right, but
The dedicated
dedicated
devices,
in
right?
the trial,
Right,
whatever has been
right.
implanted, there are more
Right.
commercial cases done with the sapien valve
Right.
than all the trial valve combined.
I mean, we're interventional cardiologists. We push the envelope,
You
right?
give them a valve, give them a needle, they'll put it there.
I wouldn't go that far, right? You have a little bit of thought behind it, too.
I mean, I actually share your concern is how long are we gonna be doing this? Because obviously the challenge in valve and MAC is not just LVOT obstruction. I mean, there is a high risk of perivalvular leak, high risk of embolization. You know, LVOT obstruction, not all LVOT obstruction are created equal.
Correct.
There are some people who do well with LVOT obstruction. Unfortunately, all complications, if you look at the 30-day data, the 1-year data, almost all complications were fatal.
Correct. So the problem is that with LVOT obstruction, as you said, not everybody has it to the same degree. But if you get somebody who gets a significant LVOT obstruction, it can be catastrophic. I mean, on the table, we've heard about cases where they had to put Impella or do ad hoc septal ablation, and it becomes a real nightmare. So the case that I showed with the anterior leaflet is extremely long and it's touching on the hypertrophy septum. This was a reasonable case to be a little cautious and be preemptive about preventing this.
And I think, you know, how much perivalvular leak you're going to have because of that. And, you know, hypothetically, you're slicing the leaflet in a different spot. So you're touching whatever the annulus there with no leaflet. I mean, the idea that people have thought about when you put a valve in MAC is creating a rim of leaflets that can potentially decrease your perivalvular leak.
So I agree with you, and this is one of the points that we made is that you puncture in the middle of the A2, so you actually have a little bit of a rim, and for the perivalvular leak, you're basically deploying your valve within the anterior mitral leaflet, and as long as you size it according to the appropriate annular size, you get a nice seal rather than be in the middle of the valve with the potential for some of the leaflets to be sort of bunched outside of your TAVR or sapien and cause perivalvular leak. So we've had no perivalvular leak and very good results with this.
One more question.
Yes, ma'am.
Just think of the concept, right? So with lampoon, you're completely lacerating the leaflet.
Correct.
In this case, you're ballooning, you're in the middle, now you're tenting it up with this valve. So you might actually pull up the subvalvular apparatus, like the muscles. And would that change the configuration, you know, below and?
So because we did this on cardiopulmonary bypass, we did not see any tenting of the subvalvular apparatus. We believe that if you do this under a rapid pacing, which you would usually do, you would not have a risk of significant migration atrially of the subvalvular apparatus. I think we would sort of position it right at the annulus, would anchor the sapien at the annulus without significant pull. And you know, whether you like the laceration or you like the translocation like the surgeons do, I've talked to surgeons that say, well, this translocation, we just slice it down. And some people said, oh, you balloon it and you actually produce a laceration that is uncontrolled. Both are true. But what we've seen on the one slide that I showed you, the valve being deployed, it's actually deployed within the anterior mitral leaflet. And we see a little tiny rim out on the sort of lumen side that actually contains the valve. So I don't think the pulling of the subvalvular apparatus is going to be a major problem. We hope. We've only done 3 cases. Yeah, I mean, the concept is there, and I hope it catches a little bit of traction. Thank you very much.